but I'm sure Dr. Iqbal Malik is going to stimulate us with this talk on the role of simulation-based specialist training in patient safety. Just a background on Dr. Malik. He's qualified from Cambridge University, then trained at Guy's Hospital, London. He was appointed as a consultant interventional radiologist 2003. He's director for clinical governance for surgery, cancer, and cardiovascular division at Imperial College Healthcare NHS Trust. He has a special interest in coronary artery disease and runs the transcatheter aortic valve implantation program. Dr. Iqbal Malik.
Thank you so much. Okay, Jazakallah khair for the invitation, and my apologies to the speakers for this afternoon because I'm going straight back to the cath lab after this. She's given a brief introduction. I'm basically a plumber. So cardiologists divide themselves into photographers, plumbers and electricians, and I'm a plumber. So I'm either closing holes or opening pipes. So that's what I do for a day job. But I'm also into patient safety, and I'm just retiring from the governance role in about a week's time, having done it for 5 years, looking at all the nasty incidents that can occur in the hospital, especially in the surgical specialties. So I also run a course which is simulation based, and that's the reason I think I've been invited to give this talk. So first of all, we can start by saying, how do we actually learn? Well, we can learn in a didactic way. That's how we learnt at school. That's not a great way of learning medicine. It's not a great way of promoting safety, because much as you are falling asleep after lunch, so do most of the people in clinical governance talks. So that's not a good way of actually doing it. Then there's the apprenticeship. You know, medicine is an apprenticeship, so my registrar sticks right next to me and learns all those tips and tricks you could not learn another way. There's a role for that, absolutely. And that is why, you know, I'm really a builder of sorts. And most surgical specialties will have an apprenticeship. But the apprenticeship days when you took 20 years to get to be a consultant are gone, because now it's fast-track training and the juniors can't stay more than 3 minutes in the hospital without having a break. And so you have to have something more in the way of actually training them up. So what is the thing that is unique? Well, I'll go into a number of different ways simulation can work, but what I'm about is immersive simulation. So you practice the crash landing, much as that pilot who landed on the Hudson River after the bird strike managed to land a whole load of people on a plane and save all their lives. It was because he'd practiced that sort of maneuver. Interestingly, not in the flight simulator. He was a glider pilot. When all the engines failed, it became a very large glider. But because he knew what to do, he landed it. So our role as doctors is, of course, first to do no harm. And so the way to actually engineer that in terms of simulation is to use real patients told to retell their story, is to use virtual patients, actors, actresses that actually know exactly what to say, so you can teach medical students and doctors how to do things. We are awash with mannequins, something simple, a toe joint, a radial artery you can puncture, something very complicated where you can pick a dead body off a street, put an aortic balloon because aorta is rupturing, take it onto the cath lab table, do an X-ray procedure, defibrillate them, all of it which is a mannequin. So there are some very advanced mannequins as well. So we can do task-based activities, teach them one thing, or the team-based activity which teaches how the team to actually work. And I'm really about the team. And then, of course, there's the computer simulation. I don't like them because you can just be on a flight simulator. Yes, it doesn't, just because you're on a flight simulator doesn't mean you're going to be an airline pilot, and it's the same with medicine. So it can be experiential. You give them an experience of doctors shouting at them, the anaesthetist coming and having a go at them, the cardiologist having a go at the anaesthetist. So you can have an experiential training, and then because you're watching it, you can say, well, that was rubbish, wasn't it? How about doing this? You can amplify the learning, because what they're really going to see may not be happening very often in real life, but when it does, it's very important to get it right. And so you can use rare scenarios and build something around that. So I'm going to show you a short video. We'll just watch.
We're going to get you sorted in a second. You've got a blocked artery down the back of your heart. That's what's caused most of your problem. Now, I've been told that the right coronary is normal, but I'm going to want to have a look at that myself. Yes?
Shock in.
Lovely.
Shock. Now we're still in VT. Charge
Okay.
again. Put 3 360.
Yeah.
Everybody clear. Sharp.
And at this stage, it might be an idea to get an anaesthetist. Well, actually, we're okay. We're okay with back and sides.
So okay, so we've got these sats are going down.
Yeah.
Do you want me to turn up the oxygen to 10 litres, 15 litres?
Yes, actually, shall we just increase oxygen and
I'm not happy with this.
yeah. So
Okay, so oxygen's up to 15 litres.
I can't breathe.
so
I don't think this is help. Can't breathe. I'm sorry.
She was fine at the start of this.
yeah.
What's going on?
So basically, I think
You get the idea. One person you'd want as your doctor, and the other one perhaps not quite yet you'd want as your doctor. Because the first one is a consultant, very cool guy. He knows what he's doing. The next one is a very junior registrar. Everyone's going, what's going on? Shall we give some oxygen? And the patient's screaming, and he's a little bit frightened in the headlights. So this is a simulation. They're both simulations, but you can see how realistic the simulation actually is. So the aim is to try and make it a bit more realistic, that dummy. So the learning, you can teach some technical skills, some haptics, and you've got some experts watching them. But it's about the communication, how you handle the stress that actually makes it much more valuable. So it's away from a computer model and into mainstream simulation. So you can see the environment is actually very much based around what might be real. And we've got igloos, sort of plastic tents you can put up anywhere. It doesn't have to be in our reception area, where you can do surgical procedures, you can do other things. So you can see the advantage of simulation in getting to desensitize the doctor and also to teach them specific parts of the procedure. So we've had lots of trainees through it, we've had trainee feedback. We now run an ST3 course, which means that at the junior level, before they get anywhere near a patient, they actually get to know how to do A, B, C, D, and E. And all the ones that have gone through just feel much more comfortable. Just like it's very difficult to prove wearing a parachute when you jump out of a plane is a clever idea. No one's done that study. In the same way, it's quite difficult to prove that the simulation makes a big difference to patient safety, because patient safety, usually there are other doctors around. What it does do is makes the team interact better, and so you will see an improvement in patient safety, but once you've done thousands of cases. So in the back room is the control station, and for any simulation you need the back room boys adjusting the scenario to fit with what is actually going on. If you just have a computer simulation runs from A to Z, does the same thing with every single simulation, it's not realistic. So the doctor could be rubbish, it'll run through with 5 complications, or excellent, it'll run through with 5 complications. What we can do is modify it so that someone who's doing really well, you could throw another spanner in the works and see what they do with that. It's modifiable. The next part of simulation is it's rubbish until you feed back. So you have to have trained assessors who feed back to say this is how it went well, this is how it went badly, and we go to town asking every member of the team, including the audience that's also watching, what their opinion was and what they saw. And what's amazing is if you have a room full of trainees, they see the first scenario, they see the mistakes made, they don't make that mistake anymore. By the time you've got the 8th scenario at the end of the day, they're just altogether better performers. And it's not an act, it's that they're dealing with the situation much better because they've got desensitized. So that debrief that we do is really, really very important. So the patient is at the center. We've got actresses and actors that do it, and their feedback is vital. We think it's gone very well, and they say, well, I felt very lonely at the top end, because most of cardiology patients are awake. But you can equally do that with pain, discomfort, the post-operative ward where the patient is not right, and they're deteriorating, they're feeling anxious, but they're not supported. Equally suitable for nurses, for allied healthcare professionals. We're focusing on the doctors to train them up. So we can train multiple specialties at the same time, so we often do anesthetics and cardiology, but you can do anesthetics in any other surgical specialty, interventional vascular radiology. So this is an example of a simulation of an aortic stent going in from the vascular radiologist, and of course the sexy thing these days is now acute stroke intervention, so we can also do acute stroke intervention where, again, time is brain. You used to say time is muscle for the heart. Less so now, we're all pretty good at getting the artery open within an hour. Now it's about the brain. Time is brain. And if you don't have your team slick, then somewhere along the way, someone takes quite a long time ordering the CT scan, doing the CT scan, faffing about, ticking 3 Venflons in, all totally unnecessary. You have to make the right assessments, get the person to the right place to do the right intervention as fast as possible. Equally relevant for your emergency surgery, your trauma. We have a trauma program as well, which does simulations. The leg's about to fall off. Is there a vascular injury? Is there something else going on? It can be modeled so that you can link the ambulance crew to the hospital, to the operating theatre. So it's expensive to deliver in that if I ran this course commercially, it'd probably be £1,500 for each candidate to pay, because the least faculty you can get away with is 2 faculty members, 4 students. Okay, so each student will get at least half a faculty member. And faculty can't be someone off the street, your medical student. Faculty tends to be at consultant level. So we all believe in it, and therefore the course runs, and I don't pay anyone because we can't afford to. But it should be the standard of care, and indeed it is in anaesthesia. It is in the airline industry. You wouldn't dream of your pilot getting onto your aircraft for the first time and saying, well, actually I've never done this before. I've got my friend standing next to me, so if it's okay if I take the flight. You'd say, I'm off. Okay, so same with anaesthesia, same with airlines. War games happen all the time. The Americans are doing the war games at the moment in the South Pacific. So it can happen. And of course, the nuclear department, the nuclear reactors, they've got lots of protocols available. So simulation, I think, is now prime time. It's well beyond just a technical exercise. It's a team exercise. And remember, there is no I in team, except for if you're running the ICAST program that I actually do. Thank you very much.
We've got time for a couple of questions.
Yeah.
Hello there, that's Raza, based in London. Simulation is great, but in real life, you're not a super specialist unit like you're in a general unit where people change, staff change on a daily basis.
Yeah.
How are you meant to get them all trained in simulation? So I think in a specialist centre, when you do super specialist techniques, it's fine.
But it's more difficult to translate into a general facility.
I'm going to disagree with you, okay? I think the very specialist stuff that we're doing is only done in cardiac centres, but I showed you the stuff that I'm very interested in. But actually, simulation happens for every anaesthetist now. Every ST3 anaesthetist goes on a simulation course, whether they're in Abergavenny or at Hammersmith. So it happens, it's part of their curriculum. And the question is why it's not part of the curriculum for your surgical trainee, for example. So first time they do a laparotomy, why the hell are they doing it on a patient when in fact there are very good simulators that can do a laparoscopic appendicectomy, they can do other things. So those are all available, and most of the Royal Colleges have bought into it. So if you're talking about your agency nurse being part of the team, of course, yeah, absolutely. But for your permanent staff in theatres, it's not about teaching them one individual procedure, but I'm including in the check how you do the WHO checklist, how you check the consent form, how you hand over when a team member changes. That's all part of simulation. I've shown you the extreme immersive end, but just as relevant to every theatre is the scrub nurse disappeared halfway through the case, didn't tell you, another scrub nurse arrived, the count went wrong at the end because they didn't communicate. That can be simulated.
And do you have similar programs for the nursing staff?
Yeah, so the nursing staff are part of this. So in that scenario, it's a nurse, a radiographer, the tech. It's not about the doctor, it's about the whole team. And you can tell if a doctor's experienced because they communicate with the team. They say, look, would you mind?
Yeah, I will just add to that. I mean, as an anesthetist, we run simulation courses regularly, and it's part. I mean, as obviously Dr. Malik mentioned, that it's a part and parcel of training. And actually, the trainees are checked during the exam as well. There is a scenario-based exam, which is basically conducted on the simulators. So that is obviously effectively true. In anesthesia, it has been running for nearly 10 years or so. Thank you. Thank you, Dr. Malik.
Okay.
Thank you so much.